Thank you for having me here and for the invitation. It's actually very nice to follow Rajita because I'm going to be talking about resiliency a little bit around those themes. And I'm going to be talking about the endogenous opioid system and also the dopaminergic system as two neurotransmitter systems that are centrally involved in the way that we interact with the environment. Dopamine from the perspective of responding to salient stimuli. It could be rewarding, but also aversive. And the endogenous opioid system as one that is involved in the regulation of the stress responses, but also hedonic function and so forth. I don't have any, and it's still strange to me. Let me just put this on. Yeah, sorry. Got it. Got it. I use a Mac, so this kind of.
I know it's
There you go. That's better. All right. It's still strange to me to talk about this from the Utah perspective. I just moved there in July, so after 20 years at Michigan is, going from blue to red is a little bit weird. But anyway, I don't have any financial disclosures that are relevant to this. So I'm going to be talking a little bit about the opioid system. So when you think about mu-opioid receptors, you typically think about pain, right? And how you regulate pain. And we know there are high concentrations of mu-opioid receptors in the periaqueductal gray, in the rostroventral medulla, where they basically are able to modulate through top-down regulation the pain signal that comes in from the periphery. That's kind of the classic idea behind the mu-opioid receptors. But if you actually look throughout the brain, and if you don't mind, I'll project and walk around like walking through. They are distributed throughout the brain, throughout the telencephalon, in the cingulate cortex, dorsolateral prefrontal cortex, occipitofrontal, thalamus, caudate, nucleus accumbens, putamen, amygdala, anterior temporal cortex. So these are actually affective and motivational circuits, not just about pain, but also involving the assessment of the stimulus salience and cognitive emotional integration, which is something I'm going to be talking about during this talk. So how do we go about this? We actually already had Diana tell you how we quantify these receptors. Basically, it's just a simple slide showing that when you introduce a tracer, this particular one is the selective mu-opioid receptor radiotracer C11-carfentanil, which is a potent mu-opioid receptor agonist. And so when you first introduce it, it becomes distributed in a manner proportional to blood flow, eventually becomes trapped in more specific binding sites over time. So you see areas like the thalamus, the basal ganglia, the frontal cortical areas, in hot colors, and cold in the occipital cortex, which is devoid of mu-opioid receptors and which we use as a reference region, so we don't have to go crazy with arterial lines and things along those lines. So then we take all this information over time and we develop it into voxel by voxel maps. These ones reflect binding potential, which is basically the ratio of Bmax, which is receptor concentration over affinity in 3D. And then we just utilize anatomical information to co-register, typically MR, and we are able to standardize, as is now standard in the field, to stereotactic coordinates, and then doing our statistics directly on 3D images. So basically, when you do these measures, and this is following Diana's talk, you have this tracer binds to these receptors in the synaptic membrane in red, and this is kind of your baseline measure, If you were to give a challenge that were to release a lot of these endogenous neurotransmitter, in this case, endogenous opioids, you would displace the tracer from the receptor sites. There may be other things going on, like changes in affinity, potential internalization. Your signal actually goes down. So that would be an indirect measure of activation. Sometimes we actually see the opposite, which is that you deactivate the neurotransmission presynaptically, there's more binding to the receptor sites, and your signal goes up. It's actually a little bit counterintuitive, exactly the opposite as functional MRI. So if the signal goes down, there's activation of transmission, signal goes up, is the activation of transmission. So we've done a bunch of different studies and experiments. This particular one I like because it's kind of evident and it emphasizes the whole idea of inter-individual variation. So we use a pain stressor. It's a simple process. Pain is a universal stressor. In this particular case, we used a standardized pain model that lasts for 20 minutes. And I won't get into it. be happy to tell you how to do this. And the intensity is standardized between individuals. But when we look at both binding at baseline and the change with the stimulus, with the painful stress, we call it pain stress, a stimulus, there are tremendous inter-individual variations. So at baseline, binding can go from like 1.2 up to like almost 3. And then when you activate the system, you do the painful challenge. Some people release a lot, like this one. Some people release very little. But this inter-individual variation, this change in the binding potential, which is a measure of indirect measure of neurotransmitter release, this inter-individual variation actually has physiological consequences. Some individuals release a lot, and this release is related to the suppression of different elements of this stressful experience in some areas of the brain, such as the amygdala, some areas of the basal ganglia, cingulate cortex, thalamus. This is correlated with the sensory quality of the pain as measured with the McGill pain questionnaire, standard way of looking at sensory elements of experience. In other areas, like the medial thalamus, for example, dorsal areas of the cingulate, is associated with the affective or unpleasantness of the pain, the affective quality of the pain. And the other areas are more related, for example, the nucleus accumbens, more related to the suppression, the capacity to suppress the negative affect associated with experience as measured with a positive and negative affectivity scale, which has absolutely nothing to do with pain. It's just a measure of internal affective state. So inter-individual variation, even in a single neurotransmitter system, is able to modulate multiple elements of this, in this case, a pain, physically stressful experience. If you were to do this with dopamine, you get similar results. And in the case of dopamine, you look at the whole thing. We basically have a control state, and where you have expectation of pain, but you don't receive it, and then you have the actual pain challenge itself. When you look at the overall effect, from a baseline, there is basically a release of dopamine all over the place. But if you look at the specific element of the experience, meaning pain minus the control state, which is non-painful, but it contains the expectation of potentially receiving it, you see release that is basically confined to dorsal areas of the caudate and putamen, which are the ones that are actually connected to somatosensory cortex. And the more the release of dopamine, this is positively correlated with sensory elements, sensory elements of the pain experience and intensity of the pain experience as rated by volunteers, while if you look at the other side, double subtraction, looking at the non-specific element, is the difference between the baseline state and the expectation of pain, although it's not actual pain. The non-specific element of the experience is related to dopamine release in the nucleus accumbens, and is related to the negative affective state as experienced by volunteers and the ratings of fear in a positive direction, as opposed to the opioid system, which is suppressive, and it went in the negative direction. All right, so I'm going to switch gears, and this goes about the whole theme of resiliency mechanisms and internal mechanisms that are actually related to treatment responses, which follow some of the themes that we heard about today. This is actually from GSK. This data that was actually provided to us by the company, and it's a simple. This is a comparison of a couple of trials. Traditional randomized control trials. This is a placebo in blue, and you have drug A, which is the new drug, against Paxil, paroxetine, a commercially available antidepressant. And in this particular case, there was no separation between placebo in blue and the active drugs, and there was no difference between the two active drugs, Paxil and the new one. This one was a failed drug trial, and didn't go to registration with the FDA. All right, so they did another one. They looked at placebo against drug A. This one was low dose versus drug A, high dose. And in this one, actually there was separation between the active drugs and the placebo, and there was a slightly better effect, although not statistically significant, between the low dose and the high dose. All right, but if you actually look at the effect of the drugs in the study A and the effects of the drugs in the study B, you will see the actual change in symptoms in patients diagnosed with depression was exactly the same. And what really differed between the studies was that placebo effects were actually lower in the second study, which went on to registrations to the FDA, etc., etc. So the drugs did exactly the same thing, was just the placebo effect. that was minimized in the second one. This went on to, led to a bunch of different things to try to, change the way they manage centers, blah, blah, blah. It's irrelevant to this talk. But why are there placebo responses in clinical trials? Well, people talk about spontaneous recovery, natural history. Things change. You evaluate the patient in day A, you evaluate them a week later, and lo and behold, things have changed. So there is typically actually a reduction of symptoms from evaluation until, say, treatment or some other intervention. Natural history. There may be an improvement in function while under observation, the so-called Hawthorne effect. This was actually described in a furniture factory, a steel mill factory, where they told the workers that, for a week they were going to be observed to look at procedures and processes to improve production, and lo and behold, production improved while under observation. But response biases. People may want to please. You are being seen by a clinician, you may give them a better rating, or you may feel that they are doing a good job if they are warm with you, etc., etc. The use of subjective endpoints, following some of the talks that we had today, whereby if you have a subjective endpoint, this is going to be highly variable. We don't know what's going on behind that. And in clinical trials, a higher likelihood of receiving an active treatment. So for example, if you were to have a 3-arm study where the probability of receiving active drug is 60% versus a 2-arm study where the probability of receiving the active drug is 50%, the placebo response tend to be higher in the ones with the more active arms because the expectations of receiving the active treatment are higher. So there is a greater level of positive expectancy. A higher frequency of appointments, greater rapport with the clinician, using the same clinicians for the same individuals in the studies. All of these have been associated with a lesser separation between placebo and active arms in randomized controlled trials, suggesting that the treating environment is also contributing to the recovery of our patients by some unknown mechanism, right? Well, more than half of the CNS trials actually do not separate from placebo. Of course, this is a huge confound in clinical trials, and as a matter of fact, has led to a dearth of new compounds for neurosciences and in new therapeutics. But you can also think about this as a resiliency mechanism. If I'm giving you something that is a sugar pill and you get better, I really want to know why, okay? And the effects of this on pathophysiology. So it actually started with pain, and that's why the initial studies that we did in the group started with the pain models. And there was the observation that in post-surgical patients or in experimental pain models, if there is expectation of analgesia during placebo administration, you believe that you are going to be given an active drug. This was associated with reductions in pain ratings. And you would say, well, big deal, right? I mean, this pain is subjective endpoint, not unlike mood or any other subjective measure, or it could be a bias in reporting. But this effect was actually antagonized by naloxone, which is an opioid receptor antagonist, and they did this multiple ways, whether open or hidden injections, etc., etc., and this has been done a million times now. In the first imaging studies using fMRI and a phasic brief pain model, a placebo in this case was a topical cream, and they did a conditioning procedure. This was associated with reductions in the activity of areas involving pain regulation and stress regulation, such as the anterior cingulate, the thalamus, the insular cortex, while the anticipation of placebo was associated with activation of an executive cortical region, the dorsolateral prefrontal cortex. And in fact, later on, over the years, rostral anterior cingulate activation and its relationship with placebo effects have now been replicated across a number of different studies and across pathologies and in healthy controls. And it's not just in the endogenous opioid system. There is evidence that dopamine is also involved. This was back in 2001 from De La Fuente Fernandez and their group in Vancouver, in University of British Columbia, showing that in patients with Parkinson's disease, and by the way, did you think that Parkinson's disease has a low or a high placebo response? Well, you would think that it's low, right? Because by the time you knew that. In any case, by the time you develop Parkinson's disease, 90% of your dopaminergic cells are dead. You think it's low. Well, it's actually extremely high. It's like 45%. Huge. In any case, so when they did a randomized control trial of L-dopa cinemet against placebo, they observed that in the placebo arm there was evidence of release of dopamine both in dorsal basal ganglia as well as in the ventral basal ganglia using carbon-11 raclopride. And in the dorsal area was associated with improvements in motor control, and in the ventral area was associated with, like in the nucleus accumbens area, was associated with the anticipation of motor improvement that the subjects experienced or reported. So we did that, and we looked at the opioid system first, because it was the logical thing to do, and we gave pretty standard clinical trial instructions. We utilized IV placebo administration, which was simply saline 1 ml IV every 4 minutes during scanning. We scanned for 20 minutes doing this. And we told them, look, this agent we are giving you may be either an inert substance or a compound that enhances the body's ability to counter pain. And they rated their expectation of improvement at about 52% ballpark. And a few things kind of came up with this initial study. Number one, we saw evidence of release of endogenous opioids in areas such as the dorsolateral prefrontal cortex, the anterior cingulate cortex, the nucleus accumbens, the insular cortex. There was tremendous inter-individual variation. The average change in the binding potential was about 15%, which is a huge change, basically equivalent to giving 0.03 micrograms, 0.3 milligrams per kilogram of amphetamine to somebody intravenously, and then measured with dopamine. And depending on the areas, some were more related to sensory elements of experience, such as the cingulate cortex, as well as the nucleus accumbens. The insula was more related to affective elements of the experience, meaning reductions in the affectivity and pleasantness of the pain, and the dorsolateral prefrontal cortex activation was actually related to the anticipation of improvement by this placebo administration. We replicated the study, changed a few things around, added the second radio tracer, raclopride, to look at dopamine, and basically we replicated and extended the findings, showing that when you are giving this placebo administration, there is evidence of release of endogenous opioids in areas involved in pain control, but also autonomic regulation, such as the peripheral gray, the orbitofrontal cortex, subgenual cingulate, nucleus accumbens, dorsal anterior cingulate. Quite robust effects, and the more the release of these endogenous opioids, the more the reduction in pain as reported by the volunteers while we were doing the study. We did that with dopamine as well, and we saw release of dopamine in the ventral basal ganglia, nucleus accumbens, ventral caudate. The more the release of dopamine, the more the reduction in pain ratings throughout the study, throughout the pain challenges. And dopamine and the endogenous opioid system were correlated with each other. In fact, dopamine release in the nucleus accumbens was related to endogenous opioid release in the same region, in the ventral putamen, in the amygdala, posterior insular cortex, anterior insular cortex, and accumbens. And what we saw was that placebo-induced nucleus accumbens dopamine release during pain was accounting for about 1/4 of the variance in the formation of placebo analgesic effects. And our interpretation of this data was that, well, dopamine is acting as a saliency signal, saying, wow, something is happening, they are giving me something, this is important, and then this is activating downstream mechanisms, because we know that dopamine and the endogenous opioid system are highly interconnected. The endogenous opioid system that then came in and engaged to reduce the pain experience in multiple components. So that was kind of the idea. Well, so there is a neurobiology of it, and we asked the question, well, what differentiates somebody who responds to a placebo administration from somebody who doesn't? We also noticed that in our studies, in about 20% of subjects, we not only didn't have a placebo response, not only didn't have analgesia, we actually had hyperalgesia. They had more pain, they had a nocebo response, which is kind of the opposite of the placebo. And in fact, if you open any kind of medication information data, you will see that even in randomized control trials, a substantial number of patients, usually it's about 15%, they will develop side effects with placebo administration. It's the so-called nocebo response. There is a negative expectation, if you want. Well, we then ask the question, what differentiates somebody who gets a placebo response, in this case was defined as more than 10% or 20%, I think it was 20% change in the pain ratings. And And also we asked the question of what differentiates a placebo versus a nocebo, somebody who had a hyperalgesic response. And the answer was that the placebo responders had more release of endogenous opioids and more release of dopamine in the ventral basal ganglia, specifically the nucleus accumbens, highly localized in the area. And the same for the placebo versus nocebo response. And if you actually look at the data, what's actually going on is that the placebo responders in green release more endogenous opioids in all these regions, as well as dopamine, while the nocebo responders actually, in response to placebo administration, they deactivated neurotransmission, meaning release went down, there was less tone. So there was a bidirectional response, depending on the individual response of the subject to placebo administration, in the direction of actually releasing more dopamine and endogenous opioids and then developing a placebo response, or having a deactivation of neurotransmission and having the opposite, a nocebo hyperalgesic response to the stimulus. All right. So what is driving this? You would think, well, it's expectations. If you're expecting that something good is going to happen, you know, you are mobilizing internal mechanisms, and we see that dopamine and endogenous opioids appear to be involved. Well, not so fast. One of the things that goes on in clinical trials is that the placebo response actually continues and is parallel to the active drug effect. This whole idea that placebo responses are acute and they go away, that's BS. Doesn't work. It's always parallel to the active drug effects. So this probably involves some kind of learning mechanism. I mean, if something is not working, it'll go away, right? Well, it doesn't. So we looked at expectations. So is this driven by expectations? And the answer is not really. When we looked at individuals acting with low expectations, meaning less than 50% expectation of improvement during, when they were going to be given the placebo, versus those that acting with high expectations, more than 50% expectation of improvement, the only difference between the two groups was actually the release of endogenous opioids that we saw before in the dorsolateral prefrontal cortex and executive area. But if you look at the difference or the relationship between the initial expectations and the so-called subjective ratings of effectiveness. So you come into a situation with a particular expectation, and this has been described in neuroeconomics, the famous Kahneman theories, that basically you are coming in with a certain expectation, but then you are observing an outcome that is not what you are expecting. So that difference between expectations and subjective effectiveness appears to be behind this, whereby if you come in with high expectations, but you are subjectively experiencing low efficacy, you have less pain. I mean, the pain actually increases, you have less of a placebo effect, and you have less release of these endogenous opioids. In this case, it's the dorsal anterior cortex. If you go with low expectations, low effectiveness, a little bit less. If you come in with high expectations and you experience high effectiveness, you have better improvement in pain, also a little more release, not much in that area. But the biggest difference is when you are coming in with low expectations and you're experiencing high effectiveness, and there is a huge change in the VAS for pain and huge release of endogenous opioids in areas in a way that is linear. So it's really the ratio of your expectation with your perceived effect that is actually driving this placebo response over time. So of course, if you have neurobiological mechanisms, you have genetics associated with them. We've looked at a few of them. I want to mention a couple of them that seem obvious: the variation in the mu-opioid receptor and also in FAH. So this is a common variation. Frequency is 15% of the general population in the mu-opioid receptor, is the famous A11AG. And the G allele is thought to have is thought to be a low function form. There's less mRNA for the mu-opioid receptor, supposedly affecting the function of the system. And we saw that the G allele carriers were actually had less binding pretty much throughout all high binding regions in the human brain for the mu-opioid receptor. But not only that, the G allele carriers also rated more higher in neo-depression and neo-vulnerability scores, and release less endogenous opioids and less dopamine in the nucleus accumbens. So they were releasing less, there was less stimulus from the mu-opioid receptor side, both from the side of the opioid release, but also dopamine release, as you can see here. We also looked at another polymorphism. This is an interesting one. It's actually very common. and is a common polymorphism, is a missense variant in the gene that encodes fatty acid amide hydrolase, which is the main enzyme that metabolizes the endocannabinoids. And the original theory behind this is like, well, we know the endocannabinoids affect the dopamine system presynaptically, so they should do something to dopamine. Well, that's not what we saw. What we saw was that the A carriers, which is the missense version, the low function version of the enzyme, were less able to release endogenous opioids compared to the homozygotes or the regular allele. Pretty much throughout all the brain. Pretty much throughout all the brain regions where we see placebo effects and endogenous opioid release. But the effect was selective on opioid transmission. We saw nothing on dopamine. It was exclusively on the opioid system, which was unexpected. And it was associated with greater placebo-induced analgesia and also placebo-induced positive affective state, but it had absolutely no effects on pain psychophysics. Pain threshold sensitivity, in absence of placebo, was unchanged. So it wasn't changing the pain modulatory mechanism, it was only changing the motivationally modulated regulation of pain and affect in these individuals. All right. So then the question is the obvious one. Are these mechanisms generalizable? Major depression has very high placebo responses. We also know that endogenous opioid system from prior studies that we had done is dysregulated in patients diagnosed with major depression, and that dysregulation is associated with alterations in the endocrine system, in the HPA axis, as well as with poor treatment responses. So we did the study, and we did a funny design. So in this one, we took the patients. It were unmedicated patients diagnosed with major depression, both men and women, 2/3 women, 1/3 men. And they came into a study, and we told them, look, we are going to give you two drugs. We are going to give you a compound that is a placebo, doesn't work, doesn't do anything for you. And then we'll give you a compound that it may enhance mechanisms that improve mood. They were actually both placebos. And we just changed the way you present it. It's actually no deception, because we expected that a placebo with positive expectations would actually activate internal mechanisms, so there was no deception attached to the whole thing. It was just the information was slightly differently phrased. So they entered there, some started with the inactive, some started with the so-called active placebo, and then we randomized them back, so we crossed them over. So everybody was within subjects assigned, and then we studied them with PET, doing administration of IV placebo, being told that this could be either inactive or active. And then they went to the second phase of the study, which was the open administration of an antidepressant for 10 weeks to see how they responded. Most of them took citalopram, a few were intolerant to some other drugs, most of them was just your standard SSRI. So, and this happened, so some baseline differences were that there was increased binding, the binding in the nucleus accumbens of patients diagnosed with major depression was actually positively correlated with symptom severity at the entry of the study. Maybe a presynaptic mechanism, compensatory upregulation, we don't know for sure, but there was that relationship. But the integrity of this myopia receptor system, meaning baseline myopia receptors in the same area, in the accumbens, was actually associated with responses to SSRI after the 10 weeks of treatment. That's the baseline data. Then we looked at the release of endogenous opioids in response to placebo administration in the scanner. We saw evidence of release, and the more the release of these endogenous opioids, when you give a placebo administration IV in the scanner, the more the improvement in mood symptoms, or the more the change in mood symptoms after your active week of placebo. So the change in QIDS, the quick inventory of depressive symptomatology scores, after 1 week of active placebo compared to the inactive placebo, was related to the release of endogenous opioids in, interestingly enough, bunch of different areas that we know are associated with the pathophysiology of major depression. Subgenual anterior cingulate, the nucleus accumbens, the anterior cortex, the amygdala bilaterally, and the medial thalamus, which is actually critically involved in the regulation of stress. It's a major area for that. Then we also asked the next question. Well, what happens, what's the relationship between these effects and the treatment response to the actual antidepressant? And the answer is, the more the release of these endogenous opioids in response to placebo administration, again in all these areas, including the amygdala, hippocampal formation, the thalamus, the more the change in symptoms after 10 weeks of antidepressant treatment. In fact, the release of endogenous opioids in these areas accounted for 43% of the variance in the antidepressant response after 10 weeks. So what's really going on is probably two different things, right? You have a expectation / reward learning mechanism that is being activated after placebo administration that is associated with mood improvement. In some people, more than others, there is obviously a fair amount of inter-individual variation. And on top of that, you may have the antidepressant effect. So the internal mechanisms are actually obscuring or at least confounding the effects of the active drug to the point where, in fact, and this is not something that you tend to see very often, so pay attention because it's kind of interesting. The individuals that were placebo responders in gray were actually the ones who did best with the antidepressant administration after 10 weeks of an open trial, while the placebo non-responders actually did worse. So these guys probably had a couple of things going on. They have the active drug effect and they have an internal resiliency mechanism that is actually being activated, and in fact overall remission rates were much greater, or greater in the placebo responder group versus in the non-responder group, and placebo responders showed also much greater improvement in depressive symptoms over the 10-week antidepressant trial. All right, so that's basically what I wanted to tell you. And basically I say that opioid and dopamine systems appear involved in the formation of placebo responses, potential across pathologies. We talked about pain, Parkinson's disease, major depression, still to be studied in substance abuse. It's an interesting story there, because substance abuse disrupts this mechanism. So, you know, what happens there? So inter-individual variation in placebo responses, some of which can be traced to common genetic polymorphisms and simple trait measures. I didn't tell you about that too long. Is relevant not only for clinical trials, but also the understanding of mechanisms related to vulnerability and resiliency to disease, including training responses. So we need to account for by the neurobiology that is actually internally activated when we interpret these clinical trials. So of course there are many questions that remain. You know, these are stress regulatory, these systems, dopaminergic opioid, are involved in stress responses, as we heard about before, and stress regulation. Well, does an integrity of these stress regulatory mechanisms influence responses to antidepressant or other pharmacological treatments? What's the interaction between placebo-responsive mechanisms and antidepressant effects? Well, there is some literature suggesting that some compounds, like ketamine, may actually work through endogenous opioid systems as well as glutamatergic. So there may be interactions depending on the compound with, you know, these mechanisms as well. Another question we don't know. Would placebo responses imply a greater response to non-interventional approaches, the therapies? Do you have better cognitive control, better cognitive internal control? We don't know. You have. And then again also would biomarkers linked to, for example, the response of the endogenous opioid system allow stratification in clinical trials. If you know that a particular opioid receptor polymorphism is involved, or FAH, would that allow you to at least clean up the clinical trial data a little bit more? Still to be done. So that's basically just acknowledging our team and our funding agencies, and I'll be happy to answer questions. This is actually from